Good morning, everyone. On behalf of my co-investigators and the entire research team, I'm honored to present the first results of ARROW, first in human, phase 1 study of a highly potent and selective RET inhibitor in advanced RET-altered tumors. I have the following research support to conduct phase 1 studies. So RET in normal cells, the RET is a receptor tyrosine kinase. It functions in a ligand-dependent manner to control organ development and tissue homeostasis. Oncogenic RET alterations that include RET mutations and RET rearrangements drive tumorigenesis. As you can see in this slide, RET is a rare driver of multiple diverse cancer types. As you can see, in medullary thyroid cancer is mutated in over 60% of the time. There is a subset of medullary thyroid cancer called hereditary medullary thyroid cancer, which is seen 100% of the time in those patients. In papillary thyroid cancer, 10 to 20% of the time. In non-small cell lung cancer, 1 to 2% of the time, and is seen less than 1% across multiple different cancer types. As you know, precision oncology has benefited patients with EGFR, ALK, or ROS1 aberrations. Unfortunately, patients with RET-altered cancers have not benefited from precision oncology targets to date. The current drugs that have been used have been repurposed multi-kinase inhibitors like cabozantinib and vandatinib. They have decreased activity and increased off-target toxicity because we call them dirty kinases that target several different pathways. So there was a need to design a selective drug for the RET pathway. BLU-667 is a designer drug that was designed to treat RET-altered cancers. As you can see in this slide, BLU-667 has sub-nanomolar potency across several RET variants, including the predicted RET gatekeeper mutation V804L and M. In the middle slide, you can see that BLU-667 is more potent than RxDX105, vandatinib, cabozantinib, the multi-kinase inhibitors, 10 to 10,000-fold more than these multi-kinase inhibitors against the RET genomic variants. Conversely, RxDX, vandatinib, and cabozantinib are more active on the VEGF-R2 than BLU-667. Among the whole kinome, BLU has significant and highly potent selectivity for RET. So this was a phase 1 study. As I mentioned, ARROW study was enrolled 51 RET-altered cancer patients. So as you can see in this, diverse RET genotypes were enrolled. The most common was medullary thyroid cancer with 29 patients, and M918T was the most common alteration. The second most common tumor type was lung cancer, 19 cancer patients. The most common alteration was a fusion. In this case, it was a KIF5B RET fusion. And we saw 2 cases of papillary thyroid cancer, both with CCD6 fusion. And as you can see, there's another patient with paraganglionoma with RET alteration as well. Let me go to the activity of RET. This is what makes a phase 1 investigator wake up in the morning and go to work. This is one of my patients. It's a 27-year-old male with a history of highly invasive medullary thyroid cancer. It was so aggressive, he couldn't breathe. They had to put a tracheostomy down his throat, and he had to undergo emergent surgery. He had so much invasion of the major vessels, esophageal and tracheal invasion. So we, in a multidisciplinary conference, we decided radiation was harmful. The current drugs, cabozantinib and vandatinib, would cause hemorrhage and perforation. So this was one of our first patients who got enrolled on the BLU-667. We saw the preclinical modeling. It was highly selective against RET, with less off-target toxicity. We started this patient at a very low level. Within a month, you can see the blue lines. It shut off the tumor marker production almost completely. And slow and steady, every month or so, as the patient tolerated the drug, we dose escalated the patient from 60 to 100. Right now, he's at 400, almost 11 months, going back to full-time work. So this is phenomenal for a phase 1 study. The next patient is, again, a 37-year-old lady with RET, this time with KIF5B RET positive non-small cell lung cancer. She progressed on chemotherapy. As you can see, the FISH was positive for the RET fusion, and the ctDNA showing the KIF5B RET rearrangement. And within 2 months and 4 months, you can see the before-after scans, she had a dramatic reduction of the tumors. And you can see the ctDNA findings that immediately the KIF5B RET gene levels drop down in the blood. The next patient, this time he's a 74-year-old man. So this man was in a wheelchair when he presented for this particular clinical trial. He had progressed on 2 lines of chemotherapy, radiation therapy. Next-gen sequencing revealed that he had this KIF5B RET gene alteration. He was enrolled on one of the dirty kinase inhibitor studies, vandatinib and everolimus. He achieved partial response. He continued on the response for 11 cycles, unfortunately had massive progression. He was in a wheelchair, dyspneic, cachectic, and when he entered the BLU-667 study. We started the BLU-667 study, and within 2 months, he was a different person. He was starting up and walking. His wife says that he never walked across the Atlanta airport. You guys all know how large is Atlanta airport. He's now able to walk in the Atlanta airport. So this was a fantastic response in terms, this was a post-TKI response for this patient. We saw also penetration of this drug at the 400 milligram, the highest dose level in the brain. So this is encouraging. So to summarize, BLU-667 has broad anti-tumor activity against all RET-altered cancers, regardless of the tumor type, regardless of the genomic aberration, fusion or mutation, regardless of prior therapies that included immunotherapy, that included chemotherapy, that included multi-kinase targeted therapy, and regardless of the number of prior therapies. So the overall response rate for the lung cancer cohort is 50%, and the overall response rate for the medullary thyroid cancer cohort is 40%. Safety and toxicity. So phase 1 studies are looking for always toxicity, right? So you can see, we did not see any grade 4 or grade 5 toxicities in this. Most of the thyroid cancer patients, the medullary thyroid cancer patients, present with diarrhea. They have 10 to 20 bowel movements a day. So this is debilitating. Once we start this drug, within 2 weeks, they have constipation, and we need to deal with constipation. As you can see, we had 20% grade 1 constipation in these patients. And for a phase 1 study, this was well tolerated, and we had 16% of the patients who had grade 3 AEs, which were considered treatment related, and most of the adverse events were grade 1. In summary, BLU delivers potent RET pathway inhibition with favorable tolerability, showing high preliminary response rates and durable activity. Overall response rate for RET fusion non-small cell lung cancer is 50%, medullary thyroid cancer is 40%, 41 out of 51 patients, RET-altered patients, remain on treatment as of date. This is fantastic for a phase 1 study. I do a lot of phase 1s. I want to say that this is fantastic for any phase 1 study because at the lower dose levels, patients may not be getting the higher doses. So ARROW dose escalation validate BLU-667 as a promising precision therapy. The ARROW dose expansion is open and enrolling globally. So the foundational preclinical work and the clinical translation, including the patients that I presented today, have been published today in Cancer Discovery. Thank you.